Hi everyone. So continuing the audio recordings for chapter 62, I believe. And at this point, we're talking about amputations. So with amputations, guys, always focusing on the fact that we are actually taking off a part of the patient. So a limb, right? So maybe it's an arm, maybe it's a finger, maybe it's a toe, maybe it's below the knee amputation or above the knee amputation, but we're cutting off a part of the patient's body, and this part is probably really closely tied to the patient, and it's part of the identity and how they see themselves, right? So it makes a huge difference post-op that we are addressing the loss of the body part, the change in body image, the fact that the patient may be depressed, may be anxious, it may grieve. Actually, they're going to grieve the body part. So some of our nursing interventions, besides the pain management, etc., specifically focuses on our addressing the loss of the body part. So our focus once again is going to be on above the knee amputation and below the knee amputation. That's our primary area of interest. So in general, in terms of definitions, so an amputation may be congenital or maybe a traumatic event caused by conditions such as progressive peripheral vascular disease, infection, or malignant tumor. And right away, you're thinking of things like diabetes when we're talking about some of the vascular diseases that the patient may be having. So ideally, the amputation is done to relieve some symptoms, improve function, improve quality of life, and save the person's life. And the saving of the person's life may be when the patient has a really severe infection, let's say, or maybe it's gangrene or something like that, and we don't want the infection to spread. So the best case scenario is for us to just cut off the limb, right? So that could be one example. Uh, Maybe the patient even has something like frostbite. So essentially, we just need to cut off that limb because there's no use for it anymore. So the healthcare team needs to communicate a very positive attitude to facilitate acceptance and participation in rehab. I cannot overestimate this last bullet enough. So your attitude has to be positive. You have to look at the place where the limb used to be. You can't be afraid. You can't look scared. You can't be looking at the patient and then your whole face is showing fear or anxiety, right? Because the patient will be looking at you to see whether or not you accept them as they are. So especially for amputations, guys, you have to watch how you are interacting with the patient. Um, I know that the first time I took care of a patient with an amputation, I had my own ideas of what I thought the patient could do or couldn't do. And a lot of times these patients are, once they've had acceptance of the amputation, they're actually pretty self-reliant and they don't necessarily want you doing things for them. So just always getting a real understanding of what the patient is able to do and not do, and not trying to do every little thing for them, because that is going to irritate the patient. So all an amputation is the removal of a body part, often a limb. So an amputation may be necessary for a lot of different reasons. And a lot of the reasons are usually because of the vascular reasons, right? So right away, you're thinking of things like diabetes, like I mentioned earlier. In some cases, the patients may have things like trauma, and specifically when we're talking about things like diabetes, African Americans may be more at risk for that as well. And African American males may even be more at risk for needing amputations. And some of that may have to do with the lack of access and lack of following the treatment protocol. And that's why they're ending up needing an amputation. Other reasons that somebody may need an amputation include things like fulminating gas gangrene. So anytime you see the word fulminating, you're going to see it here under amputation, and you're also going to see it, I believe, under hepatitis. So anytime you see the word fulminating, just think deadly, think death, think really, really bad. So this is a deadly gas gangrene. It's very abrupt or severe, and apparently it's a bacterial infection that produces gas in the gangrene, and it's caused by a bacteria, And what happens is you get this black bubbly lesions that basically form on the skin. The patient can have something like necrosis, fever, and blisters. So it gives off like a foul, sweet smelling discharge from the lesions. So treatment obviously will include antibiotics, potentially even amputation like we mentioned, etc., just to be able to make sure that that infection is not spreading. So um, when I'm talking about fulminating liver, then that means that the liver is really, really diseased and infected, and at that point, the patient can potentially die from that infection that the patient has. So other reasons for amputation, so trauma, burns, if something gets burnt and the patient's whole body gets burnt, but maybe their arm is like, something like a 3rd-degree burn and it's black, um, actually more like a 4th degree. 4th degree is like black and needing to be cut off because there's no use for it anymore, right? Things like frostbite, even potentially electrical burns as well. So we will be discussing burns, so don't forget some of this information. So when we get to burns, there are different degrees of burns, there are different types of burns, and some of the worst types of burns are the electrical burns, because with this you get the electrical discharge. It goes deep into your internal structures and it creates a lot of problems for the patient. All right, so amputations can happen at various levels. So you see it can be above the elbow and below the elbow, above the knee amputation. Once again, that's what we're focusing on, as well as below the knee and as well as the SIME. So just keeping in mind that there are different areas where a patient may end up getting an amputation. So with the amputation itself, we perform it at the most distal point that will heal successfully. And we're doing this at the most distal because we want to preserve as much of the limb as we possibly can. If we don't need to cut off, and do an above the knee amputation, and if a below the knee amputation makes more sense, then we're going to do a below the knee amputation, because it's actually always better to do, not better, but like in terms of the patient functioning after surgery, it's easier to get a prosthetic put on for the below the knee amputation versus the above the knee amputation, because most of your limb is preserved already. So the weight bearing is that much easier if it's a below the knee amputation. So we don't want to cut off any unnecessary body parts or amount of body tissue, right? We want to preserve as much of it as we can. So that's why we're going for the distal point. And in order for us to do the amputation, we're looking at 2 factors. We're looking at the circulation in the part as well as the functional usefulness. So is there necrosis present in the part? Because if there's necrosis, then probably we're going to need to cut off more of that piece. Otherwise, there's no viable tissue, so it makes no sense for you to leave that body part there, right? So we're looking at circulation. And how are we knowing that the part is nicely having circulation? Well, we're going to do vascular studies, diagnostic tests, so things like ultrasounds, Doppler flow studies, all of that. They will help us evaluate to see whether or not the patient has enough circulation to the body part. And then the functional usefulness, so that's what I was talking about. Can we put in a prosthetic device if needed, right? Can we put in a prosthesis if needed? If the amputation maybe is due to a tumor or something more aggressive like that, maybe the excision is going to be that much bigger. And then in your book, you may see that they can do what are known as immediate prosthetic applications post-op, or they can do like delayed prosthetic attachments later on. This may be like somewhere at like around page 1471, if I'm not mistaken. But just knowing that that's out there, and not all patients are going to need a prosthesis, okay? So circulatory status is evaluated through the physical examination and diagnostic studies, as I mentioned earlier. And so the muscle and skin perfusion is extremely important for healing. So I already mentioned the Doppler flow studies and the ultrasound. The angiography, so this, you should be familiar with this term at this point. So this is another aggressive test that we're going to do to see whether or not revascularization is possible to the area. So essentially we're trying to figure out if we can have a restoration of perfusion to the body part or the organ that has maybe been compromised because of ischemia. So now we're trying to see what is the potential for that area basically to have perfusion again. So we are going to look at that area via the angiography. So we're looking at the blood flow, I'm basically trying to see if anything is blocked. We're looking through the arteries or the veins, and it's basically a type of X-ray that we're using to check the blood vessels to see whether or not there's enough blood flow there. Because if there's a lot of ischemia, a lot of necrosis, like we mentioned, then we probably can't keep that limb. We may have to cut off part of it, right? So if we think that we can have revascularization, then for sure we're going to be doing an angiography just to assess the whole situation better. So type of objective is to conserve as much limb as possible as needed, and because we want to preserve function and have a good prosthetic fit. So I've mentioned already, it's the BKA and the AKA that we are mostly involved in. So, and I've said to you that we prefer the BKA over the AKA because then more of the limb is there already. Some of our complications include things like hemorrhaging, infection, skin breakdown, phantom limb pain, which is pain perceived in the amputated section, and other things like joint contraction. And this is caused by positioning and a protective flexion withdrawal pattern associated with pain and muscles, right? So wherever the amputation is, let's say for example it's an above the knee amputation, the limb would tend to move towards the body or towards the stomach. That's kind of like a protective pattern because of pain and maybe improper positioning, right? So we want to prevent all these joint contractures if we can, as much as possible. And the phantom limb pain, you're going to see that in the text. They're going to have, I think it's called mirror image therapy. Apparently, they put a mirror and then they have the patient look at the limb that's left, and supposedly that helps the patient with not having as much pain. So that's really, really interesting. It decreases sensation to that limb, and it helps the patient. So just knowing that there are different types of therapies out there that may be beneficial for the patient. I don't think I need to explain why any of these complications are a big deal. It's a massive, massive surgery, right? That's why hemorrhaging is a complication. Like especially if it's the leg, like above the knee or below the knee amputation. This is a huge surgery. You're cutting off bone, and you're cutting off major blood vessels, and that's why you can see that the patient may hemorrhage. The infection, the skin breakdown, all of that, I'm sure makes sense for you guys. So some of the things that they will recommend for a patient, in particular if they've had like the above the knee amputation, they will put the patient prone unless it's contraindicated. So they'll put the patient prone in a prone position. So remember what I said about the limb wanting to, once it's an above the knee amputation, the limb tends to contract and go towards the belly, right? So to prevent that, they may put the patient in a prone position if it's not contraindicated for other reasons, maybe for like 30 minutes, maybe 3 to 4 times a day, to basically prevent the limb from being flexed in that way. So those are some things that may be done in terms of preventing joint contraction. For the hip flexion, contraction that can happen, making sure that the patient is not sitting for more than 1 hour in a chair with the hips flexed, right? Or putting any pillows under the surgical extremity. So in general, right, when you're doing your questions, pretty much across the board, they'll say no pillows, no pillows, no pillows. Let me know if once you start doing questions, anybody's saying it's okay to put pillows. So just give me, and I want to know the circumstances of when they're saying it's okay to put a pillow. In terms of the objective, so you want the amputation wound to heal, and you want to have healthy skin for prosthetic use. Some of our medical management includes gentle handling of the residual limb, control of the residual limb through rigid or soft compression dressings. So some of them can actually be a cast initially. So of course, then we have surgery, they'll put a sterile dressing initially, and they cover it with something else, and then they'll put a cast if you need to do that, and then later on they take that off. So in all cases, it doesn't have to be a cast. It can just be another rigid type of compression dressing that they may put on as well, or it can be a soft compression dressing. So all of this just depends on how the patient reacts to surgery. Is there a lot of bleeding? Is there a lot of edema? Which dressing would make the most sense for the patient? So all of that will determine what type of dressing the patient actually ends up having. So obviously, the use of aseptic technique in wound care to avoid infection for sure goes without saying. Okay, so they can do a closed, rigid cast dressing or an elastic residual limb shrinker, and the limb shrinker. The whole purpose of that is to shape the leftover limb so that they get it ready for a prosthetic if we need to put a prosthetic over there. So see how when they cut it, it's just straight, but now they've put a shrinker on there for whatever the prescribed amount of time the doctor ordered, and then you are going to be able to attach a prosthetic so that the patient is able to walk. All right, and this is going to take time. So once again, orders are going to vary with different doctor preferences, and some of the things that they try to do to get this limb ready for the prosthetic. They'll try, like sometimes they'll force the patient to put the limb, they'll punch it into a pillow to make it strong, right? So you push against a pillow. There are different types of exercises that the patient does to get them ready for the weight bearing that's going to happen when they actually attach the prosthetic. So I'm interested from you guys to hear whether or not you've taken care of patients. I think some of you said you had patients who've had amputations and what that type of treatment looked like. So the shrinker covers the residual limb, provides uniform compression, supports the soft tissues, controls pain, and also prevents joint contractures. As I mentioned, psychological support is a huge part of the nursing care and the medical management for this patient. So you're seeing that here under amputation, it's like one of the first things that we're addressing, just because the patient is losing a limb and they are grieving the body part that they've lost, right? So a lot of the needs in rehab have to do with psychological support, the prostheses, how to fit them, how to use them, physical therapy, how to learn how to walk again, vocational or occupational training and counseling. Because now maybe the patient, because of this amputation that's happened, they need to be in a wheelchair on top of everything else. So now training them how to use a wheelchair, maybe they're in crutches, whatever it is. It's just, so you have to really just make sure that we're addressing all of those concerns. So for sure, it is going to be a multidisciplinary team approach and a lot of patient teaching. So your assessment, we're doing an aggressive neurovascular status and assessment of the status and the function of the affected extremity or the residual limb of the unaffected extremity. So you're always comparing, right? So neurovascular status and function of affected extremity or the residual limb and of an unaffected extremity as well. So signs and symptoms of infection, nutritional status, concurrent health problems. So maybe on top of this, our patient has something like diabetes, which will make our treatment more challenging. Psychological status and coping, like we mentioned, like really big, addressing all of these areas. So acute pain management, impaired skin integrity, disturbed body image. You're seeing disturbed body image for sure, grieving, self-care deficit. These are some of our major areas of concern that we have to make sure we are taking care of. The complications that we mentioned earlier, So including things like the hemorrhaging, the infections, the skin breakdown, the phantom limb pain, and the joint contractures. Just really making sure we're medicating the patient and following whatever our orders are in terms of positioning the patient. Phantom limb pain, if the patient says they are in pain, regardless, like the limb is gone, but you've done it's a huge surgery, like I mentioned. It takes a while for the body to recalibrate because you've cut off all these major vessels. Everything is really, really crazy to that area. So the body's taking a long time to figure out what the hell happened, right? So even though the limb is not there anymore, they are going to say that it still hurts. So whatever the patient says the pain is, that's what it is. You medicate the patient regardless, okay? As long as it's due, as long as it's ordered, and it's time for them to get it, you do not make the patient feel bad about that. You give them the medication. You do not argue with them. Our major goals include relief of pain, absence of altered sensory perceptions, wound healing, acceptance of altered body image, and acceptance of altered body image is huge. Resolution of the grieving process of their body part, restoration of physical mobility, and absence of complications. And I think you can see why all of these are making sense. We are for the altered sensory perceptions, we're just kind of making sure that we know, in addition to everything else, our neurovascular status assessments, our neurological assessment, even on top of everything else, making sure that everything is progressing as it should, right? So paresthesias, all of that, so making sure that the patient is able to feel things. If the wound is healing properly, there's no infection there, they're not becoming delirious or anything weird like that because of an infection that we didn't catch in time, right? They're able to let us know if the limb is up in the air or if it's down. Like all of that, they should be able to tell us. So you've heard relief of pain. You've heard relief of pain being at the top of the list. So administering analgesic or medications as prescribed, changing position of the patient, putting a light sandbag on the residual limb if that's allowed, and then using the alternative methods of pain relief. So things like distraction or even using the TENS. So this is a transcutaneous electrical nerve stimulation therapy that they do to the patient. So I'm going to ask you guys to tell me what TENS is. All right, we can talk about this therapy. I want to know if you guys have come across this. And then, so let me just write that down so I remember. All right, and then the other stuff is promoting wound healing, handling the limb gently, and residual limb shaping. So encouraging communication and expression of feelings, creating an accepting and supportive atmosphere, providing support and listening. So you're seeing how all of this is really psychosocial stuff. Encouraging patient to look at, feel, and care for the residual limb, helping the patient to set realistic goals, helping the patient to resume self-care and independence, and always referring the patient to the proper support groups that the patient may need. Okay. And proper positioning of the limb, avoiding abduction. So I want you to remind me once again where we do abduction and where adduction maybe is not the worst thing. So here we're avoiding abduction. There are other places that we kind of like abduction. Which surgical procedures have we talked about so far where we said we don't want adduction, but we want abduction? So here, proper positioning of the limb, avoiding abduction, external rotation, and flexion. Turn the patient frequently, prone position if possible, especially if it's an above the knee amputation. This is one of the ones that they usually do the prone 30 minutes at a time as prescribed. Using assistive devices, following up with range of motion exercises, so muscle strengthening exercises as prescribed. And then some of the stuff that they do for the pre-prosthetic care includes the stuff that I was talking about where they try to toughen up the residual limb, right? Where they push that that limb into a pillow, right? So this is part of the pre-prosthetic care to make that to tell the patient basically, or to help them get ready for when they are putting a prosthetic there, because a prosthetic is a hard thing that you're going to put on that limb. So we need that limb to be really, really nice and tough and strong and perfectly healed, so that we can add the prosthetic. So proper bandaging, massaging, all of these are other things that can be done for the patient in preparation. So the other things, like, like immediately post-op, it's the same things pretty much for any other musculoskeletal type of operation, right? So you've cut off a limb, you know that, it's a big surgery, blood vessels have been cut, there's a dressing there, there's edema, there's swelling, all those things, right? So maybe they've put in a rigid cast dressing, or maybe they've put on an elastic uh, limb shrinker after they've put in some type of sterile dressing underneath, because usually, like post-op after surgery, they're going to put some type of sterilized dressing that they apply directly over the sensitive areas, right? And then they'll follow up with putting all the other different types of dressings after that. But just making sure that if you once you get your patient on the floor, if you're seeing any type of drainage, whether it's blood or serosanguinous fluid, whatever it is, that you are marking that, because you want to see how much drainage there is, and you want to see whether it gets bigger and whether it's getting worse, essentially, right? There's an expected amount of drainage that's expected, and we want to monitor it closely so that it's not more than whatever the surgeon is looking for. So are they going to have maybe drains put in place because maybe there was a complication with the amputation? Anything goes, right? So if that needed to be part of it, then they would do that. Maybe there was an infection. Maybe the patient even had something like osteomyelitis, and now they ended up with an amputation, whatever. So there's so many just different types of scenarios that can happen. So as I was saying, post-op, if there's a dressing there, and there's a little bit of drainage, making sure you're marking that. And if it's increasing, being sure to report that to the doctor. So when you come back, if it's bigger, letting somebody know, the resident on call, somebody, because what they do is they make rounds anyway. So they want to know, okay, when the patient came on the floor, how much drainage was there, and maybe the 3 p.m. nurse circled it, but then maybe the nurse that came on shift later on at the end of their shift, that it was 1 inch around whatever the dressing, but now it's maybe 3 inches. That's a huge difference, right? So you want to report that, because maybe there's bleeding happening inside somewhere, and the patient might need to be taken back to the OR. So that's part of our nursing assessment. And just the educating the patient about really participating as much as they can in the care, and being a part of all the support systems that are available to them. So in a nutshell, that is what I want you to know about amputations. I want you to know that there are different levels. I want you to know that there's AKA and BKA. I want you to know the medical management in terms of giving medications. I want you to be familiar with phantom limb pain, the fact that you have to medicate the patient no matter what, okay? As long as it's due and it's not too soon, right? The fact that, with the AKA in particular, the patient can be positioned in a prone position, but that's if it's not contraindicated. What is the other fact under amputations? The body image disturbance that happens. That's a huge thing, and how you are showing up is, the patient might take cues from you.